Ну, все, дверцу закрывайте и все. Good afternoon, dear students of second stream, foreign students of third course second stream, and let's start our lecture dedicated to the closed trauma of abdomen peritonitis. Part 1, closed injuries of abdomen. Traumas of abdomen make 1% of all traumas. Actuality of abdominal trauma is conditioned by a higher lethality, which exceeds 60% in rupture of inner abdominal organs, etiopathogenesis. The most frequent mechanism of closed trauma of abdomen is a strong blow of the weakened abdominal wall, or by the abdomen either while falling on the solid object. Classification of closed trauma of abdomen. First, large group traumas of abdomen without damage of internal organs include contusions of abdominal wall and ruptures of abdominal wall. Second large group include traumas of abdomen with damage of internal organ, which subdivides into traumas with damage of hollow organ, with damage of parenchymatous organs, and combined damage of hollow and parenchymatous organs. Hollow organs are more easily subjected to rupture if at the moment of injury they are filled. Ruptures of parenchymatous organs are observed more frequently if they are previously changed by pathological process, cirrhosis of liver or malaria. The main danger in the hollow organ rupture, for example, bowel, stomach, consists in infecting of abdominal cavity and development of peritonitis. The main danger in the parenchymatous organ rupture consists in profuse bleeding with development of hemorrhagic shock and acute anemia. Typical scheme illustrated most distributed dangerous ruptures of different hollow organs and their parts. Includes ruptures of lower third of esophagus, gastric or stomach wall, wall of vesica or wall of large and small intestine. And this scheme illustrated reasons of intraperitoneal or intra-abdominal bleeding due to trauma. Include also wall of different part of intestine, kidney, also stomach, parenchymatous part of liver, and vesica urinaria, and other. Possible source of retroperitoneal bleeding include thoracic and lumbar part of vertebral column, nephrons tissue, osteoid tissue of pelvis, and retroperitoneal part of large vessels. Contusion of abdominal wall. Clinical picture of contusion of abdominal wall is manifested in cases of hematoma of soft tissues. Clinical picture of contusion of abdominal wall include pain, visually determined hematoma, in view of moderately painful tumor-like formation in thickness of abdominal wall. And in subcutaneous rupture of muscles, their defects is determined in the thickness of abdominal wall by palpation. General state of victim is satisfactory. Symptoms of irritation of the peritoneum are negative. Contusion of abdominal wall treatment. Principles. Bed regimen during several days. Called on the place of contusion for the first day after trauma. Subsequently, physiotherapeutic procedures to quicken resorption of hematoma. Hemostatic drugs and analgesics. For clinical picture of closed injuries of abdominal organs, it's of characteristic appearance of severe pains in whole abdomen with the most expression in the area of projection of injured organ. Peculiarities of clinical picture depend on character of abdominal cavity organ damage. Clinical picture of injuries of parenchymatous organs, Part 1. predominate symptoms of massive hemorrhage. Which symptoms? Paleness of skin and mucous membranes, progressive decrease of arterial pressure, pulse becomes more rapid, shortening of percussion sound, appearance of Schottky-Blumberg symptom, Phrenikos symptom, hanging of the anterior superior wall of rectum in rectal examination. In slight hemorrhage into abdominal cavity, the tenderness of abdominal wall may be an essential in positive Schottky-Blumberg symptom. Subcapsular rupture of liver and spleen may take place. In this case, hemorrhage into abdominal cavity develops in some period of time following trauma. Safety of the organ capsule is disturbed by the accumulation under its blood, even in insignificant increase of intra-abdominal pressure, for example, in sneezing, expectoration, defecation. Typical CT scan picture investigation in blunt liver trauma. Visible lacerated liver and exfused blood. In the match of hollow organs, there may be a fast development of peritonitis. Its main signs are diffuse pain in abdomen, dry tongue, thirst, rapid pulse, pointed feature of face, thoracic type of breathing, sharply expressed symptom of irritation of abdomen, abdominal parietal peritoneum. You can see operation visible defect from the pediatric surgery, blunt abdominal trauma and as subsequent of this trauma, rupture of loop of small intestine. Injury of duodenum and pancreas, peculiarities. Retroperitoneal rupture of duodenum. In injury of the posterior leaf of parietal abdomen, the content of duodenum gets into abdominal cavity and peritonitis develops. If posterior leaf of abdomen is intact, at first retroperitoneal phlegmon develops, with subsequent rupture into abdomen and development of peritonitis. Clinical picture of pancreas injury consists from the symptoms of intra-abdominal bleeding and symptoms of peritonitis. Rupture of pancreas head is often accompanied by shock. Injuries of diaphragm. Ruptures of diaphragm usually occur in combined trauma of the chest and abdomen in their compression. Tendinous center of the left cupule of diaphragm is injured more frequently. Organs of abdomen are displaced into pleural cavity through the formed defect. Clinical picture of diaphragm traumas are usually masked by the symptoms of trauma of other formations of the abdominal cavity. Injuries of kidney. At first, constant diffuse pains appear in abdomen. Then the pains are localized in the appropriate lumbar region with irradiation into inguinal region. Constant symptom in this case is macro or microhematuria. However, microhematuria may be absent in the tearing of kidney vessels off or rupture of ureter. Injuries of kidneys part 2. Objectively, in kidney trauma, the following phenomena are revealed. Anterior abdominal wall is behind head, the act of respiration on the injured side. Positive Schottky-Blumberg symptom presence. Retention of stool and gases. Tension of muscles of the lumbar region subsequently in connection with infecting peripheral hematoma. Increase of temperature may be observed. Injuries of urinary bladder. This kind of trauma, enclosed abdominal trauma, usually combined with fractures of pubic and ischial bones. In intraperitoneal rupture of urinary bladder, clinical picture is characterized by rapid development of peritonitis and stopping of urination. Extraperitoneal urinary bladder rupture is manifested by formation of infiltrate over pubis, reaching the umbilicus, lack of urination and severe intoxication in results of the urine absorption. Additional methods of instrumental diagnostics in closed traumas of abdomen. Review X-ray examination of abdominal cavity helps reveal free gas under the cupula of diaphragm in hollow organs rupture, and found out rupture of diaphragm by the presence of displaced intestinal loops in pleural cavity. Ultrasound examination of abdomen reveals presence of free fluid, blood, urine, bile, or exudate in sloping areas of abdomen. It means small pelvis and biflex. With diagnostic purpose in differentiation of shock and intraperitoneal bleeding, laparoscopy and laparocentesis should be used. In these methods, with the help of optics or fumbling catheter, it's possible to see and get blood or bowel content from the abdominal cavity. Schematically, illustration of methodic laparocentesis. Typical view of laparoscopy. Rupture of gastric wall, laparoscopic view. Treatment of closed trauma of abdomen. All patients with abdominal traumas are get to the inpatient department. After making diagnosis of injury of inner organs, a wide laparotomy, usually median, under endotracheal narcosis is performed. In second, third degree shock, a complex anti-shock therapy lasting due operation is carried on. Proper operation includes the following stage: laparotomy, arrest of bleeding. Revision of abdominal cavity, starting from the stomach and finishing by rectum and urinary bladder. Careful examination of the bowel mesenterial edges, posterior surface of the stomach, spleen, liver, duodenum, and anterior surface of pancreas. Performing of Novocaine blockade of rectogenous zone. Proper surgery intervention is performed in dependence on founded out damages. Wounds of stomach and small intestine are sutured by two-line sutures in transverse direction after dissecting the edges. Resections of hollow organs is allowed only in multiple located side-by-side ruptures or crush of the organ wall or in isolations from mesentery. Typical view of suturing of an small intestine wall after dissecting damaged edges. Resection of small intestine. In the rupture of duodenum, it's immobilized by Kocher method. Rupture is sewed up by two-line suture. Abdominal cavity are separately retroperitoneal space is drained, usually through lumbar area. In injuries of pancreas, restoration of its intact by applying sutures on its capsule and draining, like in duodenum injuries, is performed. Ruptures of liver are sewed up by P-formed or other special hemostatic sutures, often with supporting by flap of omentum major on the leg. In spleen injuries, splenectomy is performed. Typical stage of investigation of retroperitoneal space in suspicion of damage of duodenum, mobilization by Kocher, and sewing of an injured hole. Blunt trauma of pancreas. Methods of mobilization of an pancreas after opening and investigation of bursa mentalis. This is initial stage of operative treatment in reason of rupture of pancreas. Suturing of rupture of liver with help of tamponade by the flap of greater omentum. This figure illustrated suture of a large lacerated wound of liver with the help of tamponade by flap of greater omentum. This omentum has been inserted into the area of liver injury and is held in place by several interrupted liver sutures. Closed suction drainage anterior and posteriorly is accompanied by pair of leakage and estimation of drainage. Splenectomy schematically. More distributed operation in reason of spleen injury. Details of splenectomy: digital compression of pedicle and partial ligation of splenic vessels. Injuries of large intestine is sewed up by applying unloading fecal fistula above the place of injury. If the loop of large intestine is mobile, it's possible to take the place of injury out on the abdominal wall in sewed up conditional or as colostoma. Wounds of urinary bladder are sewed up and epicystostoma is applied. Extensive crush of kidneys, isolations of kidney from vascular neck demands nephrectomy under condition of preserved function of second kidney. Methodics of colostomy. Management of abdominal trauma in view of resection of damaged segment of large intestine, performing of colostomy. Exteriorization of damaged segment of large intestine. Suturing of intestinal wound and exteriorization of sutured part of intestinal wall. Isolation from free abdominal cavity. After liquidation of inner organs damage and in the presence of threat of peritonitis, nasogastral intubation of small intestine with a long perforated probe up to the ileocecal portion of bowel is of need. The final stage of operation, toilet of abdominal cavity with antiseptic solutions and draining of abdominal cavity, usually by minimal 4 drainage, suturing of operation wound. Part 2 of my lecture, peritonitis. Peritonitis is defined as an inflammation of serosal membrane that lines the abdominal cavity and the organs contained therein. Typical purulent fibrinous exfusion in distributed peritonitis. Anatomy. We divide microscopically mesothelium in square more than 1.8 square meter and including mesothelial cells, basement membrane and connective tissue. And in gross anatomy, we subdivide all this field into the intraabdominal area and retroperitoneal space. Значит, intraabdominal area include intraperitoneal and retroperitoneal. Intraperitoneal space defined by mesothelial membrane and visceral peritoneum include visceral peritoneum and parietal peritoneum. Functions of peritoneum. Pain perception of parietal peritoneum. Visceral lubrification. Fluid and particulate absorption. Inflammatory and immune responses. Fibrinolytic activity. Peritonitis is often caused by introduction of an infection into the otherwise sterile peritoneal environment through perforation of bowel, such as a ruptured appendix or colonic diverticulum. The disease may also be caused by introduction of a chemically irritating material, such as gastric acid from a perforated ulcer or bile from a perforated gallbladder or a lacerated liver. In women, localized peritonitis most often occurs in the pelvis from an infected fallopian tube or a ruptured ovarian cyst. Most distributed reasons of peritonitis or acute abdomen: biliary colon, perforated gastroduodenal ulcer, or acute necrotic pancreatitis, perforation of mecal or sigmoid diverticule, acute intestinal obstruction, torsion of ovary, usual perforated peritonitis, salpingitis, and ectopic pregnancy. Problems. Inflammation or infection of peritoneal cavity are commonly encountered problems in the practice of clinical medicine today. In general, the term peritonitis refers to a constellation of signs and symptoms, which includes abdominal pain and tenderness on palpation, abdominal wall muscle rigidity, and systemic signs of inflammation. Patients may present with an acute or insidious onset of symptoms, limited and mild disease, or systemic and severe disease with septic shock. Classification. The peritoneum reacts to a variety of pathological stimuli with a fairly uniform inflammatory response. Depending on underlying pathology, the resultant peritonitis may be infectious or sterile. It means chemical or mechanical. Peritoneal infections are classified as primary or spontaneous, secondary, it means related to a pathological process in visceral organs, or tertiary, persistent or recurrent infection after adequate initial therapy. The intra-abdominal infections are usually divided into generalized or common peritonitis and localized or intra-abdominal abscess. According to clinical cause, we subdivide acute or chronic peritonitis. Acute, as a result of suppurative process in abdominal cavity, more frequent in surgical practice. Chronic, usually with specific character, tuberculous or parasitic. According to kind of effusion, we subdivide serous, purulent, putreficative, hemorrhagic, fibrinous or hilous peritonitis. According to spreading, local, which may be restricted and non-restricted, and widespread, which may be diffuse, distributed minimum from 2 up to 5 anatomical regions, and total, distributed on more than 5 anatomical regions. According to phases of cause, we subdivided reactive, last first 6-12 hours, toxic phase, time from start of disease and from 1 up to 3 days, and terminal, lasts from 1 and more than 72 1 day and up to 3 days up to the death of patient. Bacteriology. Distributed from gastrointestinal source, Escherichia coli, aerobic and anaerobic streptococci, bacteroids, Clostridium, Klebsiella pneumonia, Staphylococcus. In other sources, usually presented chlamydia, gonococcus, pneumococcus, beta-hemolytic streptococci, and mycobacterium of tuberculosis. This scheme illustrated distribution of anaerobes between sources of intra-abdominal infections. As you see, 58% bacteroids, sporogenous, slightly less Bacillus fragilis, and others and Fusobacteria. Gram-positive aerobes, mainly distributed Enterococci, 52%, and Staphylococcus aureus, and Corynebacteria with other stems. And gram-negative aerobes, presented usually in view of Escherichia coli, 59%, Clostridium pneumonia, Pseudomonas aeruginosa, Pseudomonas mirabilis, and Enterobacter. Peritoneal infection usually caused by 2 or more bacterial strains. Gram-negative bacteria produce endotoxins. Systemic absorption of the endotoxin may produce endotoxic shock with hypotension and impaired tissue perfusion. Other bacteria produce harmful exotoxins. Infecting organisms may reach the peritoneal cavity via a number of routes. Paths to peritoneal infection: gastrointestinal perforation, for example, perforated ulcer, diverticular perforation; exogenous contamination due to drains or open surgery or trauma; transmural bacterial translocation, it means without or no perforation. Typical examples: inflammatory bowel disease, appendicitis, ischemic bowel; female genital tract infection, pelvic inflammatory disease; and hematogenous spread, very rare, in view of septicemia. This picture illustrates schematically mechanism of exacerbation of duodenal ulcer, getting of bowel content into 3 abdominal cavity, and generation of peritonitis. Upper figure illustrated endoscopic view of ulcerative defect receives due to fibrogastroduodenoscopy. Lower figure illustrates X-ray picture, falciform congestion of gas below the diaphragm. Necrotic change in the gallbladder due to acute inflammation lead to rupture of these organs and produce development of severe bile peritonitis. Acute pancreatitis also possible reason of development of acute peritonitis and development of retroperitoneal phlegmons. After opening of retroperitoneal space, visible necrotic change and extravasation in projection of pancreas and parapancreatic fatty tissue. Also may be presented pancreatogenic bile peritonitis due to necrosis or bile wall. Postoperative or iatrogenic peritonitis usually produced due to misplaced ionostomic feeding tube as a possible reason of postoperative peritonitis, or inner drainage tubes. Postoperative prolongated peritonitis after appendectomy may be due to insufficiency of appendix vermiformic stump sutures. May be formation of recurrent abscess, acute distributed peritonitis, necrosis of intestinal fat, interstitial hemorrhage within the bowel, and widespread adhesions. Main links of pathogenesis of peritonitis: appearance of pathological center in abdominal cavity, progressive inflammative process, involvement of small and large intestine in pathologic process, endotoxic shock, and multi-organic failure. You see involvement of hollow organs in the inflammative process, formation of paralytic ileus, dilation of lumen of intestinal loops. Involvement of hollow organs, loops of intestine, in the inflammative process with subsequent translocation of pathogenic microflora through intestinal wall in the free abdominal cavity. Main clinical features in peritonitis: abdominal pain, which was on movement, rigidity of abdominal wall, tenderness on rectal or vaginal examination, especially in pelvic peritonitis, pyrexia, which may be absent also, raised pulse rate, absent or reduced bowel sounds, septic shock, later stages. Typical schematical location of pain by organ depend on sources. In upper stage, maybe stomach, gallbladder, pancreas, in epigastrium. In middle abdomen, small intestine, and in lower abdomen, colon and gynecologic pathology. In first phase, reactive phase, local symptoms prevail. Nausea, vomiting, rapid pulse up to 100 per minute. Local pains in abdomen, subfebrile temperature up to 38 degree. Tachypnoea up to 28. The face is with hyperemia. Abdomen is drawn or some distended. Abdominal wall doesn't act in breathing, tensed like a plank in separate region or through the whole wall. Intestinal murmurs are inhibited. Schottky-Blumberg sign is positive. In general, blood analysis presented leukocytosis with a moderate deviation to the left. Clinical picture depends on stages. In second or toxic phase, general symptoms prevail. Nausea, frequent vomiting with intestinal content, rapid pulse up to 120, local pains in abdomen, temperature up to 39 degree, tachypnoea up to 40 per minute, adenomia, the face is pale, abdomen is strongly distended and abdominal wall doesn't act in breathing, tympanic sound in abdominal percussion, intestinal murmurs aren't had or rare and big. Symptoms of Schottky-Blumberg is positive. In laboratory tests, expressed leukocytosis and shown deviation to the left, toxic granulations and anemia. In third stage or terminal stage, one has the clinic of the endotoxic shock, nausea, vomiting with fecal smell, pulse is rapid or filiform, temperature and blood pressure is decreased, skin is covered with cold clammy sweat, shallow respiration, adenomia, consciousness is confused, toxic psychosis may develop. The face is with the color of ground or gray, drawn, haggard, hollow-cheeked. We call this face as a Hippocrates face. Abdomen is sharply distended and abdominal wall doesn't act in breathing. Also in terminal stage may be present a tangent of abdominal wall which isn't determined due to exhaustions of neural mechanisms. Intestinal murmurs aren't had, symptoms of dead silence. Symptom of Schottky-Blumberg is negative. It's associated with the degeneration of nervous elements in peritoneum. In laboratory tests, we see leukocytosis with deviation to the left. The amount of urine is decreased. A high concentration of protein usually is determined. Diagnostics. Typical investigation in peritonitis. Raised white cell count is usual. Serum amylase increased in 4 and more in a comparison with normal indicates acute peritonitis. Abdominal radiographs occasionally helpful. Erect chest radiographs may show free peritoneal gas, usually in perforated situation. Ultrasound or CT scan increasingly used. Peritoneal fluid aspiration may be helpful, with or without ultrasound guidance. In CT scan, you can see even supported clinical picture of acute appendicitis with distributed peritonitis. Intestinal obstruction as a source of peritonitis. X-ray picture, usual direct abdominal radiography. Peritonitis occurs due to increased transparency of intestinal wall for microbes and its toxins. Prognosis. Usually according with Mannheim Peritoneal Index. Age more than 50 years, plus 5 points. Presence of signs of organic insufficiency, plus 7 points. Presence of malignant tumor, 4 points plus. Term of peritonitis more than 24 hours, 4 points plus. Source of peritonitis, large intestine, additionally 4 points. Peritonitis is diffuse, additionally 6 points. Exudate, turbid, purulent, 6 points. or fecal putrefactive, 12 points. Index less than 20 points, lethality usually 0%. Index from 20 up to 30, lethality 29%. And index more than 30 points, lethality leads to the 100%. Treatment. Treatment consists of general, special, and peritoneal lavage. General care of patient, specific treatment, of course, depend on the situation, and peritoneal lavage when appropriate. General treatment of patient with peritonitis include correction of fluid and electrolyte imbalance, insertion of nasogastric drainage tube, broad-spectrum antibiotic therapy, analgesia, vital system support. Operative treatment occurs when appropriate with peritoneal debridement or lavage. Peritonitis is the indication for the urgent operation. The main surgeon's tasks are removing a source of peritonitis, sanitation of abdominal cavity, removing an exudate and content of hollow organs, draining the abdominal cavity, and preoperative preparation should be short, meaning maximum 2 hours. You can see stage of sanitation of abdominal cavity, removing of exudate and content of hollow organs. Best approach is median laparotomy. Removing a source of peritonitis includes removing affected organ or suturing a defect in hollow organs. The sanitation of abdominal cavity includes washing with antiseptics, removing the exudate with electric pump, drying with gauze. For the struggle against intestinal paresis and intestinal endotoxicosis, decompression of bowel is necessary. It's carried out with a long perforated tube introduced into dilated bowel through the mouth or nose or intestinal fistulas. You can see typical view distributed purulent peritonitis with fibrinous films. This picture illustrates the hemi-opened method of closure of abdominal cavity with suturing by the mesh zipper laparostomy. Open method of closure of abdominal cavity or packet open abdomen. Systemic complications of peritonitis: endotoxic or bacteremic shock, bronchopneumonia or respiratory failure, renal failure, bone marrow suppression, multisystem failure. Abdominal complication of peritonitis: adhesional small bowel obstruction, paralytic ileus, residual or recurrent abscess, and portal PME with formation of liver abscess. View of patient with terminal phase of peritonitis or abdominal sepsis, treated by old closed method, state of multi-organic failure. Shortcomings of closed methods of treatment of severe distributed peritonitis: increased intra-abdominal pressure, inadequate draining, and in absence of regular frequent revision and sanitation of the abdominal cavity, peritonitis makes progress. Patient on picture is intubated without spontaneous breathing, with anasarca and looks sick. View of the patient with distributed severe peritonitis treated by contemporary or open method with possibility of frequent revision and sanitation of abdominal cavity. Advantages of contemporary open methods of treatment of severe peritonitis: normal intra-abdominal pressure, adequate draining, possibility of regular frequent revisions and sanitations of abdominal cavity, and as a result, peritonitis makes regress. Patient on the picture isn't intubated, has a spontaneous breathing. Afebrile. and without anasaka looks well. Primary state of abdominal organs or loops of intestine and wound of abdominal wall in severe distributed peritonitis. Preoperative view and first relaparatomy. State after sanitation, draining of the abdominal cavity, and applying of specific postponed sutures of an abdominal wall. Repeated revision, sanitation of abdominal cavity during relaparatomy. You see diminish of serous and fibrinous films and diminish of sizes of loops of intestine and normalizing of coloration of cirrhosis. Revision of the operating wound, specific spiral suture with the aim to decrease intra-abdominal pressure and to provide good repeated sanitation of the abdominal cavity was applied. Weakening of the spiral suture and widening of abdominal wall wound edges. View of the wound after repeated sanitation of abdominal cavity. Spiral suture is enclosed. General view of abdominal wall wound closed by spiral suture. Specific device for laparostomy in planning relaparatomies for treatment of severe distributed peritonitis. Apparatus of original construction for laparostomy. That's all information for you today. Thanks for your attention. Goodbye.